Good evening and welcome to tonight's Family Connection, where we talk about and answer your questions about vaccines for students and staff. I am Dr. Admin Alexander, the Director of Family and Community Engagement, and your host for this evening. Before I introduce the panelists, I want to thank Rebecca Hillegas and Valerie Walraven for doing our sign interpretation tonight. Now let's introduce our panelists for tonight. And panelists, please share a little background about yourself. So first, I'm going to start with Dr. Nancy Welch from Virginia Beach Department of Public Health. Ms. Welch, Dr. Welch, excuse me.
You can call me whatever. I'm here to help people understand. I've been in public health for over 45 years. I was initially trained as a pediatrician, and I'm a mother of 2 grown children and a real friend of school system for sure. So I'm glad to be here tonight. I'm glad we're doing this.
Thank you, Dr. Welch. Dr. Leah Rowland from CHKD.
Thanks for having me as well. I've been working with schools across the state as chair of the Virginia Academy of Pediatrics School Health Task Force. I'm trying to assist and support with safe school reopenings and safe school practices. And I'm the mom to 3 kids in the Virginia Beach City public school system in the elementary and high school level.
Thank you, Dr. Rowland. And Dr. Douglas Mitchell from CHKD.
Hi, thanks also. Glad to be here. I'm a pediatrician, still in a practice in Norfolk, previously in a practice in Virginia Beach. I'm also the medical director for all of the CHKD practices here in Southeast Virginia. In my 30 years in the area, I'm also trained in infectious diseases, and I've spent my career working with vaccines, and part of that including researching vaccines and watching the process that vaccines go through. Since everybody's talking about kids, I've got 5 grown kids, 6 grandchildren, and they're all fully vaccinated.
Thank you, Dr. Mitchell. And thank you all for being here. And finally, Dr. Aaron Spence, our superintendent.
And thank you, Dr. Alexander. It's great to see everybody. I want to just start real quickly by expressing my appreciation for our panelists and for your willingness to be here this evening and help us answer some of the really important questions that we're getting from our community. And I especially want to thank those who are attending our webinar this evening. We appreciate so much the questions that we've received and your interest in this really important topic at this moment in our community here. I'm proud to be the superintendent of Virginia Beach City Public Schools. I'm proud to have been in this position for 8 years, 2 of which have been leading in a pandemic. And really grateful for the opportunity to have these experts with us tonight as we continue to try to lead through this moment and solve problems together. So, Dr. Alexander, with that, I'm going to turn it back over to you and let you get us started with our questions.
Thank you, Dr. Spence. So at this time, I'm going to actually turn it over to Dr. Welch to give a brief overview about the importance of vaccines and stopping the spread of COVID-19. Dr. Welch?
Sure, absolutely. In order to understand the importance of the vaccine, probably it's first important to understand what the virus does very briefly in order to cause disease. Just because someone is exposed to someone who has COVID or even gets the virus in the system, that doesn't mean they're going to get the disease. Instead, that virus has to work real hard first. It has to reproduce itself, it has to replicate, it has to multiply, it has to reach a certain concentration of a viral load. That's called the incubation period and what it does. And it's not until it reaches that viral load that it's going to be successful in causing disease. So this is where the vaccine comes into play. What the vaccine does is it produces antibody in your system so that you fight that virus. You don't let it multiply. It just is thwarted. It can't get to that viral load. And when it cannot get to that viral load, then the chances of it causing disease are much, much less. You may have some contagiousness, not much, but you're most likely not going to be sick, not going to be severely ill, and most likely are not going to transmit it to someone who could become even sicker if they develop the COVID virus. So the vaccine is our road to stop this pandemic. Extremely important.
Thank you so much for that insight. So now we're going to move into our questions. As Dr. Spence said, thank you so much for submitting these important questions tonight. Dr. Rowland, I'm going to start with you for our first question and kick us off. This question says, if my 13-year-old son had COVID-19 months ago, but has been healthy since then, should he still get the vaccine, or does he already have immunity, from catching the virus?
This is an excellent question, and one I hear a lot in my clinic. Certainly, natural infection does provide some protection against a virus. It does in most cases for many viruses. However, there's some evidence that natural immunity could use a boost from a vaccine and does better. And that's what some experts refer to as hybrid immunity, where if you've already been naturally infected, you can benefit from having the vaccine as well. We're still learning a lot about this, but in general, some of the studies, there was one in Kentucky in August of 2021, looking at adults and the rates of reinfection with if you've already had natural immunity versus if you've had the vaccine. And people who have had natural immunity only were twice as likely to have another infection. And so there's definitely some evidence out there that people can benefit from getting the vaccination. So that's why it's being recommended at this time.
Thank you. And I'm going to stay with you for the second question too. And this is actually about prevention. How can we help prevent the spread of misinformation concerning the vaccine and help educate those who are concerned?
This is an excellent question, and really, like any aspects of the spread of misinformation out there, but especially for scientists these days, I think it's first fact checking. So even if your dear friend happens to post something on Facebook or wherever you are in social media, take a minute and really look at it before you share. This sometimes goes for even mainstream news articles where things might be misquoted or taken out of context. So Dr. Mitchell and I have spoken many times about go to the source, go to the journal article itself. And if you're not comfortable with that, ask your physician, talk to the doctors about whatever you're reading. So really try to be thoughtful before spreading something, because there's a lot of clickbait out there. And then I think when you're talking to other people about the vaccine, and I know we try to do this in our offices, don't be combative, don't be judgmental. Everybody has different reasons for feeling concerned. The parents I see in my office, they all love their children. They're all there because they care about their kids. And so I think, just talking, if you have a friend who's hesitant about something, you ask politely and kindly about their reason and maybe share some of what or some of your reasons. But it's very important to not yell at each other and blame each other and come at it from that end. So it's fact checking and being non-judgmental, and then repeating the facts.
Awesome. Thank you, Dr. Rowland. That's great insight there. Dr. Welch, I'm going to come to you for the next question. Is it true that children who are vaccinated do not need to be quarantined if exposed?
If children who are vaccinated do not have symptoms, they do not need to be quarantined. So, and in fact, in the Virginia Beach system, if you looked at the high school population, there were about 50% of individuals who were exposed to persons who were positive for COVID, but they had been fully vaccinated. And so they did not have to be quarantined. They were asymptomatic. That is certainly something also. You cannot have symptoms. We'd have to test to be sure that you did not have COVID. But for 50% of folks who were exposed, they were able to still stay in school. That's important.
Absolutely. Thank you, Dr. Welch. Dr. Mitchell, sliding the spotlight to you, sir. Why is the vaccine encouraged if the virus is 99.99% survivable?
Well, again, good question. And this could almost be an hour lecture in itself, but we'll keep it just to a couple of minutes, I think. And that is that you're right, a small percentage of people truly die from this virus, but that's a significant number of people. We've had over 780,000 deaths in the United States during this pandemic. That is more combat deaths than US service people have had in all of US wars combined. It's more deaths than in the 1918 flu epidemic or pandemic. So it's not a benign virus. It is causing significant deaths. It's causing, we've seen reports, and they are true, where our hospital systems have become overwhelmed with ill people. And so vaccines is our path to decreasing those bad outcomes by providing that protective immunity that Dr. Welch talked about, so that when you are exposed to the virus, the infection is either not happening at all or is much less severe than it would have been without the pre-existing immunity of the vaccination.
I'm going to stay with you, Dr. Mitchell, for this question as well. And it states there are many vaccinated people who have contracted COVID who experience the same symptoms as an unvaccinated person. How can you ensure that vaccinated children will be safe?
Well, what we know so far is that, yes, you can still, even after vaccination, you can acquire the disease. We also know that after the disease, you can get the disease again. So we cannot expect the vaccines to be any more protective than natural immunity from having the infection itself. But we do know for a fact that infection after the vaccination is much less severe. The rate of doctor visits after with a subsequent illness is significantly less than the unvaccinated. The risk of going to the emergency room is significantly less than in those that are vaccinated. It is really true that in pediatric hospitals and in the adult hospitals right now, the people in the hospital, 98% of those people are not vaccinated. And so the vaccine's doing what we hope it would do, and that is, even though there may be infections, it's preventing the severe infections and keeping people at home rather than the emergency rooms and in the hospitals.
Thank you, Dr. Mitchell, for both answers. Dr. Spence, I'm going to come to you to kind of round it out and make sure everyone gets a question here. So Dr. Spence, how, when, and where will athletes be getting tested? And what type or kind of testing for COVID-19 will athletes that are not receiving the vaccines at the time receive?
Right, great. So testing for our student athletes is going to be conducted at their home school. That testing process is going to start in mid-November, on Monday, November 15th, and there'll be a weekly schedule that will determine which school will be testing on which days, and each school will test on the same day every week. That testing is primarily going to occur after school hours, before or after practices, but in some instances that might need to occur during the lunch period. That testing, important to note, is not going to be done by Virginia Beach City Public Schools. That testing is going to be conducted by Mako Medical Laboratories, which is a group that's been assigned to work with us by the Virginia Department of Health. And they will handle all of the testing supplies and the materials, and they will work with us to employ testing coordinators and nurses to do the testing. It's probably worth noting there's no cost to our athletes for the testing for this program. And in terms of how the testing is going to happen, Mako is going to be using a PCR test to detect COVID. And the process is fairly simple. There's an individual shallow nasal swab taken. So this isn't the kind of early test that you had to go up and dig out a piece of your brain. This is just a shallow swab. And then those swabs will be placed into a single vial that'll be taken to the lab and tested, with results available within 24 to 48 hours. And this probably come up too. So what happens while we're waiting for the results? So while awaiting results, our student athletes can continue to participate. And then, of course, we would just reiterate that if any student athletes experiencing any symptoms of COVID-19, then they should stay home until those results come back.
Thank you so much, Dr. Spence. Next question, jump a little bit here, is for Dr. Mitchell, real quick, I'm going to jump. How long have the current COVID-19 vaccines been studied with regard to children?
Sorry, I forgot to unmute. You know, we know how long the current vaccines have been out there. I mean, that's kind of the answer to the question. But a little more detail about that is, you know, the mRNA vaccines that we're using in children have been studied for 20 plus years. And they've been positioned to incorporate that technology into a situation just as this. So we have those many years of experience of the safety profile of that type of vaccine over time. For COVID itself, first of all, we now have 10 months of real life experience in adults to show us the safety with what's the number, 340 plus million doses being given. I can't think in the history of vaccines where we've done such an extensive rapid rollout with that number of vaccines in systems that we have built to detect adverse reactions and to detect them in a reliable way to keep our vaccines and to keep our population safe. And that real life rollout was preceded by these standard studies. What is not well understood is the studies now, even in children that we're rolling out, there's been no shortcuts in those studies. The studies have been the standard. How many do you enroll? How long do you follow them? How do you document the adverse experiences? And that has been the standard approach we've done for vaccines for decades. The under emergency use authorization has expedited the review process. It has not expedited the actual study process or the integrity of the data. And so that's where we can get reassurance that we have, yes, we've got a rapid thing. It's just, you know, no vaccine before this have we had the FDA meet one day and the CDC meet 6 days later to approve the use of a vaccine. So it's that process been expedited because of the pandemic and the emergency authorizations that have occurred.
Thank you, Dr. Mitchell. Dr. Welch, I'm going to come back to you. This question says, if vaccinated, people can contract, carry, and transmit COVID-19. So why do they not have to quarantine after exposure?
Well, after they've been vaccinated, yes, as Dr. Mitchell has indicated, you can still get the disease, but you, number one, are not as contagious. Number two, you're not as severely ill. So the issue related here is with regards to transmission and with regards to severity of illness. So when you're vaccinated and you don't have symptoms, the risk is very, very slim. And remember, our goal is to keep these children in school. It really is. Everyone on this panel tonight, we've been meeting frequently, and our goal is to keep the children in school and to do it safely. So we want to strike that balance for sure, keeping children in school. And if they've been vaccinated, they have low transmission rate. And when you look at the schools, actually, the school community in terms of transmission and community disease is a totally different picture than the community at large. There are only 7% of the cases in the school have been a result of transmission in the school. All the others have occurred in the community. Everybody is working hard to prevent that transmission and to keep the kids in school. So we know the risk is very low if the individual has been vaccinated. So we want them to be in school. They'll still be wearing masks, but we want them in school.
Thank you, Dr. Welch. Dr. Spence, back to you. Will vaccines be available at elementary schools once approved? If so, will siblings not enrolled at the school be able to get the vaccines as well? For example, if my 5-year-old goes to a private school and his sibling is at VBCPS, is at a VBCPS elementary school?
Yes, thank you, Dr. Alexander. And so I'm going to answer this, but I'm going to start by saying to be clear about the question, because it says, will vaccines be available at elementary schools once approved? So I want to make sure that is not confused. Available is not confused with mandatory. And so they will be available. Our intention right now is to provide vaccine clinics for students younger than 12 years old when those vaccines become available, which we anticipate is going to happen in the very near future. And at this time, we have not determined the specific sites for those clinics. We'll work with the health department and as we make those decisions. But I can say that just like we've done with the vaccine clinics in our secondary schools, it's very likely that we will make vaccines available to family and community members as well at those clinics. We've been able to do that at our high school and secondary school clinics. But of course, that will depend on the response that we receive and our ability to accommodate the number of individuals who are seeking a vaccine. But yeah, short version, vaccines, we do intend to offer clinics for students in our elementary schools, and siblings who are not enrolled should be able to get those vaccines as well.
That's great. Thank you, Dr. Spence. Dr. Mitchell, back to you. Spotlight's heavy on you right now. Dr. Mitchell, why are children who have been proven to be the least at risk of catching, transmitting, and developing symptoms of COVID-19 required to take a vaccine? Isn't there a higher risk of adverse reactions than the actual virus?
Yeah, lot of questions there. Let me back up to Dr. Spence real quick. We've not done much tag teaming off of each other yet. Let me do a little bit of that. He's done a great job of describing what will be done to make vaccine available in public settings, the school settings. I'll also just say that many, if not most, of the pediatricians in our region are preparing to have vaccines available in their offices as well. So if you want to have the conversations with your pediatrician or your primary care physician before getting that vaccine, most of us are preparing to do that, and we'll have them ready. Each clinic, it might look a little bit different. We're not going to be doing mass vaccination clinics in our offices, but it's going to be available in many sites. It's going to look different than when we rolled out vaccinations in January in adults because the supply was very limited. There is dramatic supply available as this is rolling out in the 5 to 11-year-old children. So with that said, now back to the question. First of all, no one is requiring vaccines for children at all. It's not required, with the exception of the conversation about athletes, because of the different settings that they're in from other people, and either vaccination or testing. And that's a decision that Dr. Spence can better describe than I can. But we know that all viruses and other things are transmitted by a lot of people. We did say early on in the pandemic that we thought the transmission and the infection rate in children was very small. That was the information we had early on. It's clear as we immunize more of the older population that now we have increased transmission in kids. A much larger percentage of the infections now are occurring in kids than there were early on. So it absolutely can be transmitted. We do know that kids can become sick. There have been several hundred deaths in the United States in the pediatric age group. It's not the same 780,000 total, but any child loss that can be prevented, we should try and prevent. And that's what we can do with vaccines. If we use vaccination, we can decrease transmission. So we're keeping our children safe, but we're also then, by vaccinating children, keeping older, high-risk individuals safe as well. Kids are more likely to carry virus with fewer symptoms. And if we can prevent that, we can then prevent moving it on to higher risk folks with greater risk of complications and death. Is there a risk of adverse reactions? There are adverse reactions to these vaccines. We know that. I had my booster dose because I'm in healthcare. And 24 hours later, I was achy and I had chills. It was gone in 2 hours. Is that an adverse reaction? Yes. Is it expected? Yes. Was it permanent? No, it was not permanent. We are not seeing permanent adverse reactions to the vaccines in kids whatsoever. All of those, even the myocarditis, that a very small number of teenagers have been admitted with, is temporary. It goes away with no long-term, lasting, permanent harm from the vaccine. But we know infection from the virus does and can cause permanent, long-lasting harm, either from death, small numbers in kids, or the myocarditis that occurs with MIS-C, which is a complication in kids, can cause long-lasting effects on the heart and in the patients. And then there's always the long COVID, those that have long-lasting effects that we don't completely understand yet, but none of those things happen from vaccinations. So no, the adverse reactions of vaccines are not worse than the long-term effects of natural infection.
Thank you. I'm going to stay with you for 1 second. What about children with asthma? How efficient is a vaccine for those children? And then the second part of that question is, if there is a reaction, who is held liable for adverse reactions from the vaccine?
Well, asthma is absolutely the folks that we want to be immunized. They have pre-existing lung disease, and we have seen over time that they're more likely to have a more severe course of illness from the virus. And so people with asthma or other chronic conditions are exactly the people, both pediatric and adult, that we want to have vaccinated and prevent those long-term bad outcomes. Liability, I'm not an attorney. Okay, I'm not gonna go there. I do know that we also have risk of bad outcomes in kids that are not vaccinated. And so how do we parse that out? So we're all in this together and doing the best we can to prevent illness and prevent disease.
Can I add on to one thing that you said, Dr. Mitchell, that I thought was interesting, is that historically that's always been an issue, with any vaccine. And I know this is under emergency authorization, which is a bit different than our historical vaccines, but I have found it interesting to learn that all of the adverse events that we've seen in historical vaccines have really been seen in the first 6 weeks. So when the FDA studied this vaccination in particular, that's why they chose that 8 weeks mandatory, looking for adverse events. So I think that's important to point out, that there aren't long-term effects seen with vaccines in the past. So.
Thank you, Dr. Mitchell and Dr. Rowland. Dr. Rowland and Dr. Welch, the next question is, you two can share. So if my child does get the vaccine, will this ensure that they don't have to wear a mask in school?
No. The mask could be a very quick answer, but that's not going to help anyone who asks the question. So the mask is mandated right now, and there's a very good reason for it. Number one, I just shared with you that of the cases in the school, only 7% have occurred as a result of transmission within the school. All the others, in other words, 93%, occurred related to acquisition in the community, and that's because of the mask. The mask is very, very effective. The Mayo Clinic did extensive studies on that, and it showed what a barrier that just the regular mask can be in preventing transmission. So no, for all the reasons that everyone have heard, no vaccine is 100% effective. This vaccine is 90% effective. That's far more than flu. I wish flu would be that effective. Flu is 40 to 60% effective. So this vaccine is far more effective than the flu, but you've still got that 10%. And if you're in that 10%, you're in that 10%, and you can become infected and certainly then become ill or spread the disease. But as we've said before, there's less risk of severe disease and the contagiousness is not as high. So because we want to prevent the transmission, because we want people, the children, to be able to stay in school without disease being transmitted, the masks are a vital component of that mitigation strategy, and it's proven itself to be effective.
If I may add one additional way I like to look at it, and that is, as we started this, we did, I think we even got published, our Swiss cheese model, where you've got various layers of protection. We knew it was masking, and we did distancing, and we did wiping down surfaces, and we did monitoring temperatures and symptoms upon school entry and those sorts of things. And we've learned over the months that some of those were not as useful. Where we're at now is we know that vaccines are helpful. We know that masking is helpful. And by taking this approach, we're saying we're not going to go to just one, because no one is 100% protective. We still need combinations of those mitigating factors, and that combination is what's going to keep us the safest.
I think we can also look at the fact that there's a lot of different factors that come into what mitigations are required based on what's going on in the community, the transmission within the school, the community rates overall. And so it's very important to think, well, how can we get back to some type of normal? How can we see smiles again? Everybody wants to get there. And one very important way of getting there is vaccinations, especially, I mean, adults. The more vaccination that we have in a community, the more we're going to be able to start to consider peeling the layers of the mitigations. But vaccination is the path.
Thank you all for your responses to that. Dr. Welch, another question for you. For children ranging from 5 to 12, when the vaccine becomes available, is it going to be mandatory for those children? And what will happen if us as parents do not want our 5-year-old to have the vaccine?
No, it will not be a mandate. This is an emergency use authorization, and it's not like, I know a lot of parents are accustomed to the DPT or meningococcal or some of these other vaccinations that are required for school. And quite frankly, those requirements come from the state legislature. They're the ones that decide which ones are really going to be mandated. And there is no indication, no reason, no expectation that this vaccine would be mandated at all. We encourage it, and we want people to take the vaccine. As you've heard many times here, the vaccine is the path to the end of the pandemic. The mask is the means to reduce the transmission as we're walking that path. So both of them together is what will get us to the end point, but it will be a voluntary decision on any family's part. There is no way that we anticipate or even want to ask for a mandate for this vaccine. I think everyone on this panel is a parent, so I think we can identify with that. We want to protect our children. That's what we want to do. That's our unified goal, to protect the children and get them in. So yes, we encourage you to talk with your doctor, to read the information that we have provided. You've done the first step. You've come tonight and listened to the program and heard the information, and I hope it allays your fears and helps you feel much better about what you can do to protect your child, to protect your family, to get us onto a greater road of normalcy. We're all eager for that, but we can't do it as long as the pandemic is here.
Well said, Dr. Welch. I'm going to stay with you for the next question as well. This involves doses. So what is the timeline on getting dose 1, dose 2, and then the booster?
Yes, the number one, the Pfizer dose for the younger children is a third what it is for the 12 and over. So it's a smaller dose. And actually, most parents are accustomed to this with medications. It's when you do medications for children, primarily you're doing it by weight, but on vaccines, they're doing it based on this age. So the vaccine is, I forgot your original question.
That's okay. That is all good.
We've
it's
had
late.
so much here.
There's a lot going on. It's late.
Dr. Rowland, that's what you said you did.
So the question was just the timeline for getting dose 1,
Oh,
dose
yes,
2.
gotcha.
All good.
All good, all good. So the timeline is number one, the second dose is 21 days after the first dose. at least 21 days. Now, that's not to say you can't take it at 28 or 30. You can take it later, but you can't take it any sooner than that 21 days. And again, just like any of the other vaccines that children take, their timelines, and it's a 21 day for the vaccine.
Thank you. Thank you, Dr. Welch. And we all needed a little bit of a laugh right there. So I appreciate that too.
Pediatricians are good at that.
Dr. Rowland, this question comes to you. Is heart inflammation one of the adverse effects of the vaccine? And if so, how will our school-age children be affected if given the vaccine?
So we've alluded to this question a couple times: heart inflammation, myocarditis, pericarditis. It's important to know with the 5 to 11-year-olds coming down the pike for likely approval for the vaccine that they're getting 1/3 of the dose. And so those studies have not found any adverse events, but everyone knows that, we're going to need very, very large scale over the population to see what the incidence of myocarditis might be in that group. But it's felt that the lower dose will likely be tied to a lower risk of this. But I did pull some numbers because I feel like it's very difficult sometimes to comprehend what the numbers are actually and compare it to risk overall. So if you look at 1 million vaccine doses administered in each age group, the expected rate of, and we're going to look at men 12 to 17 years. So looking at boys in the 12 to 17-year-old group, you can prevent, by vaccinating 1 million, 5,700 cases, 215 hospitalizations will be prevented, 71 ICU admissions prevented, and 2 deaths. And the expected myocarditis cases in that group would be between 56 and 69. So the other issue is that, so you're looking at 56 to 69 myocarditis cases, but you've prevented 71 ICU admissions. So the other issue is that not all myocarditis is exactly the same. So vaccine myocarditis, when I was looking at some of the data about how fast the recovery is, and it's very quickly recovered. So this is not all myocarditis is the classic type of myocarditis that can be caused by things like influenza, other viruses that exist out there. And so that's important to know that when it does occur, kids from the vaccine, kids recover very rapidly from that. So having a 14-year-old boy myself, I've looked at this data both as a pediatrician and a mom. And so I think the numbers here are very important. And feel free, Dr. Mitchell, to jump in and add to that.
I don't have anything to add. You did a fantastic job.
Awesome. Dr. Rowland, I'm gonna stay with you because this is a very common question, and families want to know what drugs are actually in the vaccine and what are the side effects, and will you provide the exact same FDA approved vial and not a vial that's a replacement?
When we administer vaccines in our office, there is a process with a lot number and all of this that's recorded. And if you, as an adult, have gotten your COVID vaccine card, there's a little spot there to put the lot number on there. So that way it can be tracked. So there's not folks mixing up random things in random vials. It's all very organized, knowing where everything has come from. So it will be in the all appropriate traceable vials with the cards provided. As far as the side effects, they're very similar to what's seen in adults, although some kids might not really get much of a effect at all. Sometimes some fever, some pain at the site in the arm, fatigue and headache are the most common reported. Anything to add there, Dr. Mitchell or Dr. Welch?
I would just say that the vaccine for 5 to 11 is in a different vial. It's the same product, it's the same vaccine, made the same way, but because of the difference in the dose, it's being brought out to us in a different vial. a vial with an orange cap on it. And so the dilution volumes are a little bit different. The number of doses in a vial are a little bit different, but the product is exactly the same. They are also extending how long we can store it. You may recall early on that we had a lot of problems with storage because we had to keep it at -80, and there's limited number of -80 centigrade freezers out there. We're able to keep this much longer in our refrigerators in our offices. With that said, just to reemphasize, particularly in pediatrics or in family medicine, primary care, vaccines is what we do. We have very specific national and state guidelines and laws that we must follow in providing vaccines to our patients. And we are monitored by the Vaccines for Children process within Virginia to make sure that we're keeping everything stored appropriately, documenting appropriately, and none of that is changing with this vaccine. As a matter of fact, it's even a little heightened with this vaccine from what we typically do with other vaccines.
Thank you, Dr. Rowland, Dr. Mitchell. Dr. Mitchell's questions for you again. Why is there a difference in quarantine procedures based on vaccination? Asymptomatic individuals vaccinated and unvaccinated can and do spread COVID-19. Why are unvaccinated kids required to quarantine if they are asymptomatic and wearing masks? Isn't it the same exact risk either way?
You know, Dr. Welch, I think, has addressed this as well, and it's, you know, it is confusing, and how we communicate is confusing. The bottom line is that we know vaccination decreases the risk of acquiring the vaccine. We know that it decreases the amount of virus that you have if you do become infected, and so therefore it decreases the risk of transmission. If you combine that with masking, you're adding an additional layer of protection for decreasing the risk of transmission. Some of it is a practical decision. What is our reward for getting vaccinated if we would have to do exactly the same things? And so we are taking a little bit of an approach of, by vaccinating and wearing a mask, if you have symptoms, you can continue to go on with your life because you have added that additional layer of protection and decreasing the risk of spread to other people.
Thank you, Dr. Mitchell. And so we're almost halfway through, so I'm going to skip down just a little bit. And this question says, my son has had COVID-19 3 times and has antibodies. With proof of such, does he still need to get a COVID vaccine? And I'm going to open this up to the group.
Well, I'll go ahead and take it. You know, and yes, you're right. I think that question also proves one point, that the point we've been trying to make, that even if you've had COVID, it doesn't 100% prevent getting it a second or third time. And that's what we see with the vaccine. So how can we expect our immune system to do any better with a vaccine than we do with natural infection? And that applies to many things. You know, we've been talking about this for decades. If you get the chickenpox vaccine, you may still get a very mild case of chickenpox, but you're not going to have the blisters and the pox all over the body. You're going to have a few red dots, and you're not going to have the complications. And so that's what we do with any vaccine, is we decrease the risk of complications down the road. So the second part of the question is that the antibodies that we measure are not necessarily predictive of protection. We don't have it that well refined yet. And so using the approach of, yes, you've had infection, we can boost that protection by using the vaccine, is the best way to move forward.
Thank you. Dr. Mitchell, I'm going to stay with you for this question as well. Are all COVID-19 vaccines FDA approved? And what's the difference in them all?
So the process to getting to where we're at, as we've seen multiple times compressed over the last year, is any vaccine that we've ever had goes through a process where it's presented to the FDA to show safety and effectiveness. And then it goes from the FDA to the Advisory Committee on Immunization Practices, a committee of the CDC, to then use that information and that recommendation to decide upon our best step forward for public health measures and individual health measures based by people that are multidisciplinary, that are looking at the public health things. So that FDA then leading to CDC is the approval process. All the vaccines that we have right now have been through that process and have received at least the emergency use authorization from the FDA, endorsed by the CDC, getting us to where we're at. Remember, as I said before, that process, that emergency use authorization, has not done a shortcut on the science or on the safety. It's done a shortcut on the approval process to get us there. So the full, if you will, FDA approval, no longer under emergency use authorization, correct me if I'm wrong, I think it's just so far for Pfizer, 12 and above, 18 and above, 16 above for Pfizer is now the Comirnaty brand name that's been put to the Pfizer. That's the only vaccine for COVID so far that in the United States is no longer under emergency use authorization, and so you would consider it full approval. But all of the others are under that same emergency use authorization process through the FDA, through the CDC, to get us to using those vaccines.
Thank you, Dr. Mitchell. Dr. Rowland, the next few questions are for you. Dr. Welch spoke a little bit about this for students, but this question is more for people. Explain why fully vaccinated people are required to wear masks?
Yes, I think we've hit this already, is that right now, when we're in substantial and high transmission, and we're really just trying to we want kids to be in school. We want kids, kids are a more susceptible population when they haven't had access to the vaccines. We want to reduce quarantine. So for all of those reasons, the mandate was passed. And that's the last reason, it's mandated right now. So there's not really another option. But as far as that's the reasoning with the CDC.
And the next question for you is, how long after testing positive, then testing negative for the virus, is it safe and effective to get the vaccine?
In general, I'm just hearing that after your isolation period is over and but I would also add to that, we like people to be feeling better and recovered. That's a general, for giving any vaccine, we give lots of vaccinations to kids with runny noses because sometimes it's a continual process when they're little, but we like people to be feeling better when they get vaccinated. Would you add anything, Dr. Mitchell?
I agree completely. Feeling better and beyond the 10-day isolation period. It is also worth mentioning that there's really no recommendations for testing negative after infection. We know the isolation period needs to be for 10 days. We know the risk of transmission after that 10 days is incredibly small. I can't say it's zero, but it's incredibly small. But there's no recommendations for testing to prove that the infection is gone before ceasing isolation.
And we'd also add that if folks have received something like monoclonal antibodies, that would change things, but that would likely come up with their physician.
Thank you both. Dr. Spence, coming to you, does VBCPS or VBDPH recognize natural antibodies from individuals that have had COVID and have antibodies?
So I don't speak directly for the Department of Health, although I think I'm right, and Dr. Wells can weigh in, that from a health perspective, there's not a standard for recognizing this as a way to confirm immunity. I will say Virginia Beach City Public Schools, just in terms of how we approach folks who have had COVID, we do not, as has been talked about a little bit already, we do not require individuals who've had COVID-19 in the last 90 days to quarantine following an exposure, and that follows CDC guidance. And as we move towards having our student athletes either vaccinated or testing, we have indicated that student athletes who have proof of a positive COVID test in the last 90 days aren't going to be required to be vaccinated within that 90-day timeframe or to test weekly at their schools. Once they're outside of that 90-day timeframe, they'll have to have one or the other.
Thank you, Dr. Spence. And another question for you, sir. Will staff be required to be vaccinated? And if not vaccinated, will a test be required? How will this be done? And what about testing? What about testing the vaccinated?
So right now, what we know is that the Federal Occupational Safety and Health Administration, or folks know it as OSHA, has been directed to develop guidelines for mandatory testing that have come down from the administration. That applies to federal employees. It applies to organizations with over 100 employees. Now, I also understand that in any state that has a statewide OSHA plan, and Virginia is one of these states, that school division employees will be required to be vaccinated as a part of this guidance. Right now, however, we don't have that guidance from OSHA, and it hasn't trickled down to the state level. That will be overseen at the state level by the Department of Labor and Industry. And so we don't have any of that information in order to help our teachers understand what vaccine mandates may look like for our teachers. Once we have that information, I'll be in a much better position to answer that question. And the same would go for any testing that might be required for our staff.
Thank you, Dr. Spence. All right, we're rounding out the questions, ladies and gentlemen. So Dr. Welch, coming back to you, does vaccinations guarantee a person will not catch the virus?
No. I think you've heard a lot in this conversation tonight, which I'm so pleased to have the pediatricians here and the people from Children's Hospital. It just really, I think, reinforces the medical component. And no vaccine is 100%. As I said, the effectiveness of this vaccine is 90%. I wish flu was as effective. It's only 40 to 60%. So that means that there is that 10% who, for whatever reason, did not develop the antibody response that would kill off that virus so then it could not become ill. Remember the sort of illustration that I used at the beginning, that even with that virus gets in your system, what it has to do to cause disease, it's got to multiply, it's got to replicate, it's got to get to a certain load, it's got to have enough quantity that it can cause disease. And the vaccine, again, 90% of the time will reduce that. It will stop that virus from replicating. It will keep it at a low level, so it cannot get up to an adequate amount, but it still can have a small enough amount that still happens to reproduce. And so that's why someone who's vaccinated can have symptoms, can have the disease, but in a very mild form, and they're not contagious. But I don't know of any vaccine that is 100% effective.
Thank you, Dr. Welch. Dr. Rowland, this question is for you. It's just about existing conditions. Will there be existing conditions that will qualify one to not get the vaccine?
Really, the only one that is an allergic component, having an allergy to a component of the vaccine or a previous reaction to the vaccine. And that's been seen extremely rarely. Did you have anything to add, Dr. Mental? I don't have any of that.
And the last question goes to Dr. Spence. Is the vaccine booster encouraged for staff who have been vaccinated?
So the answer is yes. We encourage all of our staff to be vaccinated. That certainly is one of our key mitigation strategies to keep our staff and our students here in school, as has been talked about quite a bit, both on this webinar and elsewhere. And so the answer is we encourage our staff to get vaccinated, and then we encourage our staff to get the booster as recommended by their physician. So we would always encourage our staff to talk to their physician, but certainly if that's appropriate for them to get the booster, then we would definitely encourage that they do so.
All right. And then one more question, Dr. Rowland, is for you. And what research has been done and is available to the public to show that the vaccine will not harm our children in the future?
I think all of the information that's out there thus far, the FDA trials, I think it was an 8-hour webinar, 8-hour YouTube, where you can look at all of the information that they use to make the decision for the 5 to 11-year-olds. All of the information is out there. I think an important piece of this is that they have several systems in place. Some are new to monitor for adverse events. And as Dr. Mitchell had said before, never in our history, I think, have we had, there's 414 million doses of COVID-19 vaccine have been given since December, just through this week. So that's a massive number. And there's a lot of monitoring occurring. And in addition to that, we as primary care doctors on the front lines tend to see things before they're published. And so we've been very reassured as far as what we're seeing in our emergency departments and in our offices, that there's not adverse events happening that are being missed.
All right. And then I'm going to turn it over to Dr. Spence for this last question, Dr. Spence. Are there accepted exemptions for the vaccine, i.e. religious exemptions?
Thank you, Dr. Alexander. Yeah, so I want to be really clear about this. The vaccination is not required for anybody at this time, so there really aren't a need for exemptions for the vaccine. And I know there was a question also asked earlier about whether or not the vaccine would be mandatory for students, for example, starting during the next school year. And I don't intend to make that decision. And I think you heard Dr. Welch say that she doesn't think that that's something that would be mandated. But in any case, that would only happen if the state determined that that should be added to the list of mandatory vaccines. And even in that case, we would need guidance on how to address that for already enrolled students. So for either our staff or our students right now, there's not a requirement for vaccination. So exemptions aren't required. And there are no exemptions for our student athletes, because in that instance, the vaccine is not required. There's an alternative for the student who wants to participate in athletics. They can participate in our weekly testing program. So we really don't need any exemptions for the vaccine in the school system. We're not in a position where that's necessary. So with that, I think we've reached our last question, and we're at the end of our allotted hour. So I would love to close this out by simply thanking our panelists one more time, Dr. Welch, Dr. Mitchell, Dr. Rowland. Your expertise, your commitment to our community, your commitment to your patients and to public health is commendable. And really, I hope that people found this to be informative. I know I did. I learned something every time I talk with the three of you. And, I hope too that the message is clear, that we're really appreciative of our families who've joined us this evening and who have these questions and concerns, and we recognize that, and we value the opportunity to learn more together. Challenging times lead to challenging decisions, and those can sometimes lead to challenging moments. But I think it's in these moments where we can rise to be our best. And I want you all to know that that is our commitment here in Virginia Beach City Public Schools, to be our best for one another, and especially to be our best for the children of this city and children in our community. And that's our commitment to you, that we will continue to do that work every single day. So I do want to just note, in case anybody's curious, if you've got folks who wanted to attend but weren't able to, that we will be posting this webinar to our COVID-19 information site on vbschools.com. You'll need to give us about 48 hours so that we can get it closed captioned, and then it will be up and available for anybody who needs to to see this. And with that, we're going to sign off. Thank you all again so much for joining us. And I hope that you all have a wonderful rest of your evening.